I'm Dr. Ray Christensen, faculty member from the Department of Family Medicine and Biobehavioral Health at the University of Minnesota Medical School, Duluth campus. I'm also a family physician at the Gateway Family Health Clinic in Moose Lake. I'm your host for our episode tonight on eye problems, including cataracts, glaucoma, macular degeneration, and other vision concerns. Remember, the success of this program is very dependent on you, the viewer, so please call in your questions or send them in our email address, to our email address at pbsnorth.org. Our panelists this evening include Dr. Cole Swiston, ophthalmologist and glaucoma specialist from Essentia in Duluth, and Dr. Todd Brittain, a surgical ophthalmologist from Ralph Eye Care in Duluth. Our UMD medical student phone volunteers tonight are Nick Whiteman from Brainerd, Minnesota, Madeline Guler from Pelican Rapids, Minnesota, and Dane Nelson from Glendon, Minnesota. And now, on to tonight's program on eye problems, again including cataracts, glaucoma, macular degeneration, other vision concerns. If you have them, please call in. Dr. Brittain, welcome back. Can you tell us a little bit about your practice?
Yeah, so I work at Ralph Eye Care in Hermantown, and we provide comprehensive eye care for all ages. I see patients of all types and treat all ocular conditions. My primary focus surgically is on cataract surgery and eyelid surgery.
And Dr. Swiston, you work over at Essentia. Tell us a little bit about your practice at Essentia.
Sure. So like Dr. Brittain, I see a lot of comprehensive eye care, but I have a subspecialty for glaucoma care, both medical and surgical management, and then a little bit of a niche in complex eye surgery as well. So I've been at Essentia for a year and a half, kind of building that practice up, and it's been going good so far.
As a start, do you want to talk to us a little bit about glaucoma, what it is?
Sure. So glaucoma can sound quite scary and complex, but it boils down to just nerve damage. And the nerve that gets damaged is the big one that comes off the back of the eye, the optic nerve. And what generally drives that damage is high eye pressure, which can be caused by a number of different things. But as the nerve gets damaged, you usually lose your peripheral vision, so from the outside in. And that's what's scary about it, is that you really don't know that your pressure is high, and you don't know that you're losing peripheral vision because it's not part of the vision we use day to day. So it's something that needs to be screened for and detected by an eye doctor. And we can't reverse the nerve damage once it's happened. We can only slow it down or stop it. And we do so by lowering eye pressure, which we can do with eye drops, lasers, and surgery, or a combination of those. And that's my bread and butter and what I see every day.
I'm sure there's a lot of variations and levels in this. Todd, I'm sure you're taking care of a lot of glaucoma also. So you're more of a general ophthalmologist. Is that a fair discussion point?
That's correct.
So for glaucoma, what kind of things do you do?
Yeah, for glaucoma, I provide laser surgery. We're often doing laser surgery as first line treatment now for lowering the pressure in certain types of glaucoma, primarily in open angle glaucoma. I do a lot of combined surgery with cataract surgery to lower the pressure, and also, medical management, with drops.
What's the difference between open angle and closed angle?
Yeah, it has to do with the drain within the eye. In some patients, the drain isn't as functional as it should be, but it is fully open, and that's what we call open angle glaucoma. The eye is constantly producing fluid, and if that fluid can't leave the eye, the pressure increases within the eye. And that is in contrast to narrow angle glaucoma, where the actual drain is narrower than it should be, and that's what's preventing the fluid from leaving the eye. And the two are treated in different ways.
So Cole, this kind of brings us to where you are. We've got the basics on this. Where do you step in with the specialty, the glaucoma specialty part? Tell us a little bit more.
Sure. Yeah, I mean, glaucoma is so common throughout the U.S. that it can't be managed strictly by glaucoma specialists. There's a horde of optometrists, general ophthalmologists who do a wonderful job taking care of it. But there are points where the laser's not covering it or the drops aren't covering it, and then you kind of need to increase that care. So patients are referred to me when their glaucoma is, progressing or getting worse, despite the best efforts of those caring for it. And that's when I step in, usually with likely a surgery. And there's a realm of glaucoma surgeries out there, from minimally invasive, which Dr. Brittain talked about and combines with cataract surgery. So we do quite a bit of that. But then there's some more invasive and therefore more effective glaucoma surgeries as well. From tube shunts and bypass procedures and strong lasers, there's quite a few different options, and this is one of those fields that's expanding almost faster than we can keep up with it. And so it's always helpful to meet and form a relationship with that doc that's going to be doing the surgery, because you may very well not just need that one, you may need subsequent, because it's unfortunately a lifelong disease and it's incurable. It's just something that we can manage and treat.
At what age do we, and either of you can answer this, what age do you start, when does it begin? Is it start in childhood or in young adolescence, or is it an older person's kind of problem?
I wish it was that simple, because you can come out of the womb and have congenital glaucoma, be born with it, and you can develop it as a juvenile and you can develop it as an adult, but by far the most common risk factor is age, as well as family history, and then just high eye pressure. So in general, you're going to see more of it in the 5th, 6th, 7th decades of life for sure.
Switching gears, kind of, Todd, what is Sjogren's disease with the eye?
Yeah, Sjogren's disease is an autoimmune condition. I primarily see patients with Sjogren's disease who are having problems with dry eyes. That's when they are typically referred to me. Can affect other parts of the body, including the salivary glands. So in addition to dry eyes, Sjogren's patients also have dry mouth. Where my care usually takes place is in treating the dry eyes. With Sjogren's, we'll start with lubricating drops, warm compresses over the eyelids, and anti-inflammatory medications. There are a couple that are out on the market that can be effective.
I think we probably need to move to cataracts. Cole, what are cataracts?
Yeah, it's common. We all die, we all pay taxes, and we all get cataracts, unfortunately. So within the center of the eye, you have an M&M shaped lens, and when you are born, that is crystal clear, and that gives you a lot of the focusing power of the eye. But in everyone, as we age, it just gets cloudy over time, and that dulls out the vision, makes it harder to see detail and color, and then can give you a lot of glare at night with night driving. And it can be accelerated in its development by a few different things: diabetes, smoking, trauma, a lot of UV exposure, steroid medications. And when it gets to the point where that vision just isn't good enough, that's usually the time when you'll get referred to a surgical ophthalmologist for management and cataract surgery.
So there's this question sitting here: how do you know when it's time? And either one of you.
I'll take that one.
Yeah, it can be tough sometimes because it does sneak up on people so slowly. I think probably one of the number one symptoms that people notice is glare. And we always ask about glare with night driving. Especially in this part of the country, it's impossible to not drive in the dark during the winter months. So patients will notice that oncoming headlights are more bothersome. For those of us who try to avoid driving at night, you may not notice that. So what you may notice more is that you need more light in the house in order to see well. You might find that you're switching out light bulbs, trying to get the brighter lights to see better. And then what we see on our exams, we'll start to see a shift in the glasses prescription. Oddly enough, a lot of patients will become more nearsighted, as the cataracts progress. So we'll see that shift in their prescription. And eventually there will come a time where we can't correct the vision with the glasses, and people are bothered by it. And that's how we decide, when it's time for cataract surgery. most patients, they have an idea, especially when you reach that age range and you're having breakfast with your friends and they tell you all of their symptoms and they tell you that they just had cataract surgery.
It's the way to get the yellow out.
Exactly.
It works pretty well.
Yeah.
I think it is one of those things that people tend to put off, right? It's like you didn't realize how bad it was, and then you probably hear all the time, like, I can't believe how well I see after I got it taken care of.
Definitely, yeah. I think the classic thing is we do cataract surgery on one eye at a time. And so we always hear from patients, between the first surgery and the second surgery, wow, my eye that you operated on, it's bright white, and my other eye is yellow, because they're doing them, we call it the one-eyed salute, where they're covering one eye, covering the other eye, and they notice that difference.
Yeah, or I can see all the dirt in my house now.
So, one of you tell me a little bit how does a cataract surgery work? I've been through it. There aren't any stitches. It was really quite simple and straightforward. What do you do?
Yeah, so modern cataract surgery is pretty slick. I don't like to call it easy because I feel like patients get the sense that there can never be anything that goes wrong, but as far as a surgery, it is very routine, very straightforward. Generally, you come into the surgery center and get just a little bit of sedation, so the edge is taken off, and a micro incision, like a 2 millimeter incision, is made in the eye, and then that cloudy lens is suctioned out with a special machine and then replaced with an artificial clear lens that lasts the rest of your life. And if you're going to remember anything from that process, it's just going to be some really bright and what's often described as psychedelic lights. And then the recovery is generally very quick too. Your vision comes back in the first few days. Your eye is just a little bit scratchy and you use some drops generally to help the eye heal. But as far as surgery goes, I have patients who come in who have gone through heart procedures, joint procedures, and then it's just like a walk in the park compared to those.
It is, that's true. We kind of touched on autoimmune earlier. I think, Todd, it was you that had done that. There is a question here. How dangerous is an autoimmune condition on the eye? We touched on Sjogren's a little bit.
Sure. Yeah, it can really depend on the on the condition. I think primarily with autoimmune conditions, what we worry about is inflammation within the eye, just as you can have inflammation elsewhere in the body with an autoimmune condition. We generally classify inflammation within the eye as uveitis, and inflammation within the eye can affect all different layers of the eye, from the most anterior portion of the eye all the way back to the posterior portion of the eye. Our job as ophthalmologists is to treat the eye and also, think about the patient's overall health and make sure that we're doing the right things to further look into the cause, of the inflammation. And that can include things like sending a patient for blood work, sending a patient for imaging, MRIs, CTs, and just working through the condition in order to treat it as best we can.
As a family physician, I've always appreciated having you guys around when it comes to taking care of uveitis and some of those, and there's others too. Cole, are there any upcoming breakthroughs in macular degeneration treatments? So I think maybe tell us what macular degeneration, we probably should start there.
Sure. So you hear it all the time, and you probably see ads on TV. The macula, when we're talking about macular degeneration, is the part of the retina in the back of the eye that's your centermost vision. So the macula is responsible for that, reading a book type vision. And it's just what it describes. It slowly degenerates. You have these junk products that build up in the macula. And it's classified into these two broad categories. So there's dry macular degeneration, and then there's wet macular degeneration. So traditionally, dry macular degeneration, we haven't really had good treatments for. There's been a formulation of vitamins that's pretty extensively studied that is called AREDS vitamins, and those are usually recommended to just slow down the progression, but it can never be reversed. Now, admittedly, I'm not a retinal specialist, but I know that the latest kind of holy grail is to try to find some sort of injection or medication that can be put in the eye to reverse that dry macular degeneration. And I believe there is one on the market now that reverses some of the atrophy associated with it. And I don't administer that medication, but I know that's something that's coming down the pipeline. Within the world of wet macular degeneration, fortunately or unfortunately, there is a treatment for it, but that treatment is injections in the eye and usually doesn't reverse the swelling or the wet part of that degeneration, but does keep it at bay. And I think there's always kind of new medications coming down. Whether or not any of those work better than the other, I think kind of remains to be seen.
Todd, can medications like lisinopril cause eye pain? And I'm pulling my mind, I don't think so personally, from my family medicine aspect. But
No, I don't know of any
I don't
ocular
think
side
so.
effects from lisinopril.
Another question that's kind of recurring through here too is, are there medications? I'll stay with you, Todd, on this one. Are there medications that we should be taking to protect our eyes? And I think you started out a little bit with the dry eyes and probably some drops, but there's vitamins and all these things that are on television. Any guidance?
Yeah, I think.
Or either one of you. So.
Yeah. One that I'll commonly recommend for patients who have a strong family history of macular degeneration who may not want to take the AREDS vitamins, which are designed for patients who actually have macular degeneration, would be lutein and zeaxanthine. These are carotenoids. They've been shown to increase the layers within the macula that are affected by macular degeneration. These nutrients they're showing up more and more in multivitamins. So if you take a multivitamin, you may already be taking it. You can also increase the foods that you eat that contain lutein and zeaxanthine. These foods, think of anything that's orange, including eggs. Egg yolks actually have a lot of lutein and zeaxanthin in them. In general, though, I think, if you can do things that are good for the heart and good for the brain, then it's going to be good for the eyes, because there's a lot of crossover there.
The question that comes up is the Mediterranean diet also, and carrots.
Sure.
So when I was a little kid, way back on the farm, carrots were good for your eyes. Is that still the case? That's what you're saying, basically.
Definitely. Yeah, definitely.
One of the other ones that had come up in the questioning was Ocuvite. Is that helpful?
I believe Ocuvite is just a brand name or a different type of this AREDS vitamin, which contains the lutein zeaxanthine that's recommended for macular degeneration. In the world of glaucoma, there's been some data now to show that a cousin of niacin called nicotinamide is helpful in kind of preserving nerve function. So I recommend it universally for my patients with really advanced glaucoma, just to get what we can out of that remaining nerve. But if I was diagnosed with early glaucoma, I'd be taking 3,000 milligrams of nicotinamide every day, for sure.
Interesting. The other one that comes up with new things is, and I think we touched on dry eyes before, is there anything new? And this person is from the Hibbing area, like glasses, but then there's this other one that, something else that's being advertised with a little thing by the eye. Is there another drug, a drop that you can use, MIE or something on?
Mibo.
Mibo, yeah.
Sure. Yeah, so Mibo is an oilier drop that you can use. So to kind of think about how these medications work, you have to think about why our eyes are dry. So our eyes are dry mainly because of two reasons. Either you're not making the tears like you should, or the tears evaporate really quickly. One reason why your tears can evaporate really quickly is you don't have a really good oil layer within your tear film. And so Mibo is designed to target that. So it's an oilier drop, stays on the eye longer. I've had good success with it.
I was going to ask you that. I haven't actually prescribed it. I was curious.
Yeah, it works quite well. I'll use it for a lot of patients. where I really think their tears are evaporating quickly. It's worked well for some of my patients with Parkinson's disease, because Parkinson's patients, they don't blink as much as they should, and so their eyes are more prone to drying out because the tears evaporate. So the Mibos worked really well for me with that. Another treatment that's been successful for us is radio frequency to the eyelids. It's a treatment, it's called Forma, and so this also targets the oil glands within the eyelids, opens them up more. Usually patients require about 3 treatments, and it's been quite effective.
So is Mibo pricey?
It is, yeah, it can be, depending on insurance coverage.
Cole, does a family history of age, how does a family history, age, and Graves' disease influence glaucoma? Is there anything on the risk? I don't know of anything on that one.
So I guess to understand the question, are those 3 related? Are Graves' disease and age related to glaucoma?
Or I was interpreting as, does age affect, and we know that affects glaucoma.
Right.
Does Graves' disease?
Generally, no. So Graves' disease, just as an introduction, is a disease of the thyroid, and for whatever reason, the antibodies in that case that attack the thyroid end up attacking the tissue around the eye, and the eye can bulge out and swell. So rarely, if there was enough bulging, it could press on the nerve and cause damage, just as glaucoma would, but not generally.
Todd, a person asking, shed some light on a branched retinal vein occlusion. I'm not familiar with that one.
Sure. Yeah, so a branch retinal vein occlusion is an occlusion of a small vein within the retina. The reason it often occurs is the retinal veins and arteries cross, and they cross within a sheath that coats both of them, and the artery often presses on the vein and pinches it off. So you can think of the vein as being like a garden hose, and it has blood traveling through it, and that blood can no longer travel through the vein, so it spills out into the retina, causing swelling. It's sometimes treated with injections to get that swelling to go away. And then we try to manage the underlying risk factors, which tend to be high blood pressure, diabetes, obesity. But with good treatment, the prognosis tends to be good.
There's a question of too much success. This person has had cataract surgery and gets too much light. I've not heard that before.
Yeah, I tend to hear sometimes, at least in the early period, that folks are a little bit light sensitive. Now, I've generally found over time that fades away. I don't know if you have different experience with that.
Yeah, I do find that it gets better. I think some of it is just that change from having a cataract to now having a lens that's completely clear. Right. But it does tend to get better.
Eye scratches, a couple, 3 days, not getting better. Suggestions? Go get seen. This person was thinking about milk and lavender oil and so on. I think that's not where I would go with it. I think that person needs to have a look at the eye.
Yeah, tough to know if it actually is a scratch, right? It could be a number of things,
Yeah.
and you don't want to treat it with the wrong thing.
Stints in the eye because of eye pressure, and pressure gets too low afterwards. Can that happen with glaucoma?
Yeah, it's rare after some of these minimally invasive stents to have too low of pressure. It's also rare, but a little bit more common after a bigger glaucoma surgery. It can be kind of indicative of something else going on in the eye as well. Generally, low pressure is fixable, whatever etiology that is.
Possibility of dry eyes and not able to use drops because of arthritis. I don't know anything about that one personally.
So I assume they're looking for alternatives to
Yeah,
drops?
yeah.
So warm compress is helpful. Again, applying heat to the eyelids to treat the dryness. I usually recommend 10 minutes once or twice a day. And then there's actually an artificial tear spray, which I've used for some patients, where it's an interesting product. They spray the lubricating medication onto their closed eyelids, so that can be easier for patients with arthritis.
Time is running away from us, gentlemen. This has been a really great discussion. I've enjoyed the back and forth, and there's been a lot of information passed. I hope that the public enjoyed it. I want to thank our panelists, Dr. Todd Brittain and Dr. Cole Swiston. Please join Doctors on Call next week, where Dr. Krista Coity and a panel discussion will occur on cancer, including prevention, diagnosing, staging, grading, and treatment, with panels from around the region. And if you're looking for more tips, tricks, and conversation about health and wellness in the Northland, make sure to check it out on Northland Balance on PBS North YouTube channel. Thank you so much for watching and joining us for season 44, all right, on Doctors on Call. Good night.